Let's talk about membranous nephropathy. So, in the renal system or in nephrology, you find that there is a pre-renal cause, there is a post-renal disease, and there is a renal disease. In the renal disease, you find a vascular disorder, there is a glomerular disorder, and there is a tubular disorder. In glomerular disorder, there is nephrotic syndrome and there is nephritic syndrome. In nephrotic syndrome, there is minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis. Okay, so these three diseases are there. In nephritic syndrome, you may find the post-focal glomerulonephritis. Membranoproliferative glomerulonephritis may present as nephrotic or nephritic syndrome. Okay, the other symptoms like IgA nephropathy is there, amyloidosis are also some other disease which include in nephrotic syndrome. So let's talk about membranous nephropathy. And in the membranous nephropathy, the first point is about how the patient present. So you know that it is a type of nephrotic syndrome. So 70% of patient present as nephrotic syndrome, in which you find that there is nephrotic range proteinuria like more than 3.5 gram in 24 hours. You find a patient has edema and you find there is hypoalbuminemia. Okay, so these are the feature of nephrotic syndrome which is seen in membranous nephropathy. There are 30% patient who is asymptomatic. Okay, so on routine checkup they may find as proteinuria and low albumin level, but they are asymptomatic, they may not develop edema. So these are the presentation of nephrotic means membranous nephropathy. The second thing is about the causes. So there are two causes, one is primary causes and another is secondary causes. So in primary causes, there is a development of antibody against the intrinsic antigen which is present in the glomeruli, like phospholipase A2 receptor antigen and thrombospodin 7A antigen. So the antigen, these are two antigen which is present in the kidney. So you develop antibody against this antigen and there is a formation of immune complex which cause membranous nephropathy. The most important things is about the secondary causes, in which you have to remember mainly the four type of causes. The first is about malignancy like colorectal carcinoma. Okay, so mostly colorectal carcinoma is associated. So if patient present with membranous nephropathy and you find or you do a colonoscopy, there may be a chance that patient has colorectal carcinoma. The second is hepatitis B virus and syphilis, also schistosoma, because these infections may leads to development of membranous nephropathy. In SLE we can find everything, and there is some drugs like penicillamine or gold. So in these also we can find mercury. Okay, so these are all the secondary causes of membranous nephropathy: colorectal carcinoma, hepatitis B virus, SLE, penicillamine, gold, mercury, syphilis, and schistosoma. And the primary cause is antibody against these two antigen, phospholipid A2 receptor and thrombospodin 7A receptor. By the name membranous nephropathy, you can find that there is thickening of capillary basement membrane. So when you do a biopsy, in a biopsy, we do a light microscopy, we do a immunofluorescence, and what is body electron microscopy. In the light microscopy, we find there is a thickening of capillary wall. There is a deposition which is subepithelial, so it looks like a thickening of capillary wall. If we use a silver methenamine stain, we can find the figures like this, in which this is a capillary loop, this is a capillary, and there is endothelial cell. So you can find this black staining of the capillary loop which shows about membranous nephropathy. There is not hypercellularity, there is a thickening of basement membrane which appear as a thickening of capillary wall on light microscopy. This is about immunofluorescence, which is positive for IgG plus or minus C3. Okay, so it is granular pattern. Linear pattern is only seen in good pasture syndrome. So it is granular immunofluorescence, and you can see this is a capillary, this is the basement membrane, this is a podocyte, and just beneath this podocyte is a visceral epithelial cell. Just beneath this epithelial cell there is a blackish IgG C3 deposit that we can find, and there is a protrusion of basement membrane through this deposit, so it is appear as spike and dome appearance. Okay, so spike and dome appearance we can see, in which the dome is this deposit and spike is this basement membrane. So it is a subepithelial, it is epithelial, below that it is subepithelial deposit. On light microscopy it is appear as a thickening. On electron microscopy you can see the spike and dome appearance. In light microscopy also we can see by using the silver methenamine stain. So these are the three microscopic features that you should know. When we go about treatment, we know that if the patient present as nephrotic syndrome, then the modified Ponticelli regimen is used, which include oral steroid. Okay, so oral steroid and cyclophosphamide. This two drug, which is known as Ponticelli regimen, is given if patient present with nephrotic syndrome. If patient is asymptomatic, then we can use ACE or ARB inhibitor to control the proteinuria, or if the patient has some microhematuria. So these are about the treatment of membranous nephropathy.